Clinical problem solvers. Recording is in progress, and it is Neurology Morning Report. It's Tuesday. Excited to see everyone here. You know the routine. If anyone has brought a case they'd like to present, we'd love to have you present it. And of course, we will need 2 volunteers, ideally one identifying as a woman and one identifying as a man if possible. And feel free to volunteer in the chat. And while you're deciding whether you might like to volunteer, Maria has a very exciting clinical problem solvers announcement. Go for it, Maria.
Ooh, it sounds so formal. Hi, everyone. As you know, we've done like 500 of these VMRs or more. And time has come and to get some feedback from all of you. We're conducting a survey. It's completely voluntary, and it takes around 15 minutes. It has questions on all types of VMRs, and I'll post the link. It would be really cool, and we'd be incredibly thankful if you participate on it, and we can get feedback, improve on some of these, and also write a couple of articles we've been working on. I'll attach the link for the survey, and I'll also attach the link for the IRB information if you want to take a look at that info too. So that's the formal announcement I had to make.
Awesome. Thank you, Maria. Yeah, this is really important to us at Clinical Problem Solvers to see your feedback and be able to report to the world what we've been doing and how it's been going. So we'd love to have everyone's participation. With that in mind, who might like to discuss a case today? Does anyone have a case? Okay, well, we have a backup case from Gabby. Oh, we can volunteer to present via discussant. Great. Okay. Did you have a case, the White Army, or how would you like me to call you?
I have a case. I can choose to be a presenter or be a discussant. Both are okay.
Okay. Well, who else would like to, excuse me, volunteer to discuss? And we'll see how we can have you participate, Vijay. Who'd like to discuss with us this morning? You might be thinking, oh, I thought it was medicine morning report. I thought we were going to talk about interpreting liver function tests. I'm more comfortable with that, not neurology. That's okay. This is a safe space to learn neurology in a fun, relaxed way. So don't worry about that. And no takers. You might be thinking English is not my first language. I wouldn't be that comfortable. Well, we have Spanish speakers and Portuguese speakers and French speakers and lots of different speakers of different languages. So we can always help you translate something if you need. Any takers? Vijay is all alone. He wants some company to discuss this case. So we'll have Gabby present the case just so Vijay, we can have you discuss. Anyone like to discuss with Vijay? We just need one more person and then we'll be able to get started. All right, in order to inspire that last volunteer, maybe Gabby and Vijay can introduce yourselves, and hopefully that will inspire one more volunteer.
I think we have one more volunteer in the chat.
Oh, great. All right. Dharman, great. So yeah, you want to all 3 introduce yourselves and then we'll get started.
Yeah, I think I'm going first. My name is Gabriela. I am a neurologist from Brazil, and I've been participating with the CP solvers for more than 1 year now, and it's been a long time since I've presented a case. I'm excited to know what you think about this case, and I hope you like it.
Great, thank you. We're excited for your case. Vijay and Dharman, like to introduce yourselves. Let us know where you're joining us from.
Good morning, good afternoon. Yeah, go ahead.
No, you go ahead.
Good afternoon, good morning, or good evening to everyone. I'm Vijay. I'm a third-year internal medicine resident from Bangalore. I've been following CP solvers for about 1 to 1.5 years. neurology has not been one of my favorite comfort zones. So excited to learn more.
Great. Well, thank you for exiting your comfort zone, and we hope it will feel a little more comfortable as a zone at 10 o'clock today. Darmin, help me with the pronunciation. Darmin.
Yes, my name is Dharmin. I am from India and I am currently an intern student rotating in the government hospital.
Great.
And I am
do you mind?
excited and nervous at the same time to discuss a neurology case
Yeah,
with you.
so am I. Great. And if you don't mind me asking, what part of India are you joining us from?
I am from Gujarat,
From
western part
Gujarat.
of India.
Okay, so we have North India and South India represented today. Fantastic. Great. All right, Gabby, go ahead and give us the chief concern and we'll be off to the races here.
Yeah, of course. The chief concern is worsening of migraines.
Worsening of migraines. Okay. Vijay, when you hear worsening of migraines, what comes to mind?
So I think, like you always put it, localization would always be time course, and the differential diagnosis would be a localization and what is the time course. So I think the base rate or epidemiology of this patient would be very high for us to consider what would be the differential we are thinking of. So whether if it is a male versus a female. So in case it is, if the patient has a well-controlled migraine, and if it is new onset, most common would be, I would think, if is this patient compliant to the medication, or if it is not, is there something else happening in the neuraxis? So what would be the pain sensitive structures in the brain that I would think of? And based on that, I would place my differential diagnosis based on the time frame. And because headaches is there, so one is whether it is acute versus subacute versus chronic, so the time course. So those would be my thinking processes. So I would not forget to consider thunderclap headaches, which would be more sinister. And other is the raised ICP headaches, which would have an occipital presentation with waking up the patient from sleep, or postural variation like lying down or coughing or sneezing. So those are my thoughts. So any SOL or versus a vascular cause. So I'm thinking in terms of that.
Yes, fantastic, right? So we heard worsening of migraines and you made the important point that let's just back up and talk about headaches in general. And you said, so we need to think about localization. People might say, well, that's easy. It's something in the neck or above if it's headache, right? We're not worried about the spinal cord or the peripheral nerves, neuromuscular junction. But as you said, we can still think about what is pain sensitive in the head. So for causes of headache, I divide them well, first into primary and secondary headaches, right? Primary being the syndromic headache conditions that don't necessarily have a clearly defined underlying etiology, but are well described in terms of their syndromic characteristics, things like migraine, tension, cluster, and other less things you're concerned about here, because this patient has a so-called red flag, right? That their headaches are, whatever they were before, are changing and worsening. And we have to think about the pain sensitive structures that can give rise to headache. The way I divide these up are things inside the head, things of the head and neck, and then systemic causes as a third category. So inside the head, the brain, of course, is not pain sensitive, but if there is pathology in the brain, it can start putting pressure on pain sensitive structures like the dura, which is another intracranial structure, right? So we're thinking about basically brain and the meninges and the blood vessels, right? As all of things that can have pathology that could cause secondary headaches. And then of the head and neck, I mean not inside, right, of brain, meninges, and vasculature, but of the head. So problems with the skull, problems with the eyes, nose, mouth, sinuses, problems of the neck, all of those can cause headache. And then third category, systemic, we all know we can get a headache with a systemic illness, a flu. Many people have headache after the COVID vaccine, right? I had a very bad headache and wondered, what is this? Is this a mild inflammation of my meninges, or am I dehydrated or tired, or what is that? So that's how I sort of think of localizing quote unquote headache. Is it in the head, of the head and neck, but not inside, or systemic? And medication is also part of systemic, right, can cause the side effect of headache. Great, so that sort of gives us a first framework here as far as we're thinking about headaches and are they going to be primary or secondary. And so what I'll ask you, Darmin, as we think about this, we're about to hear the history. What sort of questions would you have on the history to try to get at what's going on here?
I would like to ask about the characteristics of migraine. That is the patient experiencing the headache as new characters, or is it the same migraine headache she experienced in the past? Then I will also ask about the danger signs of headache to rule out the potentially dangerous cause. And then, as you said, I will ask about the other associated symptoms like eye complaints or ear complaints or sinus complaints to rule out the secondary headache cause. And if I cannot find any secondary headache cause, then I will ask about the duration of symptoms and recurrence of symptoms, so that we can divide it, categorize primary headaches and diagnose it accordingly.
Brilliant, fantastic, both of you. I'm thinking through this case on just 3 words so far, right? So the patient may use the word migraine, and they may be quite correct that they have migraines, but some people just call their headaches migraines, and some people call their migraines headaches, right? They don't realize they have migraines. They think they have recurrent sinusitis because they can get congestion with their migraines. So we really want to ask the patient what they mean, right? And to describe the headaches. Maybe they sound like migraines, maybe they don't. And as both of you said, a concerning feature here is worsening or change, which is one of the many things on the list of red flags, many of which were also mentioned by both of you. This is Neurology Morning Report. Presumably, Gabby's going to give us some neurologic etiology here, but that's very true, Darmin, that a lot of patients have headache from eye strain. They just need new glasses prescription, or from sinusitis or some other process, again, of the head, but not inside it for a neurologist. So we'd want to take a detailed history describing the headaches. As Vijay mentioned, describing the time course. What is this history of migraine? Is that some separate thing and now something new is going on? Or is actually this whole thing a chronic process that was misdiagnosed initially as migraine? Or did the patient have what we would all agree are migraines, but now something has changed the frequency or character of those migraines in a way that worries us that something else is going on? So having laid out that framework, which both of you did brilliantly, this will allow us to hear the history and sort of decide what potential directions we might be going down and what red flags we may be seeing here. Great. Okay, Gabby, what happened when you took a history from this patient?
Yeah, of course. This was one of the reasons I brought this case, was to discuss the differences of migraines and headaches, because some people usually tell they have migraines, and we have to think if they have all the criteria. So the patient was a 35-year-old male that presents to the clinic with worsening of migraines. He developed, this is what he said, he developed new headaches 15 days ago, only in his left side temporal region, with photo and phonophobia, nausea, and without vomiting. He denies any pain related to or developing after a Valsalva maneuver. The duration of the pain was less than 1 hour, but he was not sure because the pain was very severe. From the start of the pain 15 days ago to today, he has been having pain daily, and the pain has a pulsatile characteristic. He denies any oral symptom. He went to the emergency department 1 day ago, where he was treated with intravenous NSAIDs and no improvement of the symptoms. He denies any pain during sexual activity or orgasm. He denies worsening of headache while sleeping or laying down. He has been using Dipiron daily for the past 15 days, 1 to 2 grams per day without relief. He denies systemic symptoms like weight loss or fever. He denies he was vaccinated to COVID and denies exposure to any sick contact recently. Previous medical history, he has been having 1 episode of similar pain per year since his 20s, but the other episodes lasted lasted less than 1 week, and he doesn't know the diagnosis. He thought it was migraine. He's a smoker, less than 1 pack per week for 10 years. He doesn't use any medications. Family history is negative for any history of headache in his relatives. And allergies and social history, nothing relevant to the case. This is the end of this eloquent.
Great. So just to make sure I understand, this new headache developed 15 days ago and has been continuous since then, Gabby? That's why he keeps taking the medicines every day, or?
He said he has some episodes of pain that gets worse during 1 hour and then gets better, but he has been having a lot of episodes per day. But he has pain-free episodes during the day.
I see. So for the
Not
past
continuous.
15 days, he's had multiple brief episodes of this headache that is pain-free.
Yeah, that's it.
Great. Okay, Darmeen, you told us what you'd like to learn from the history. Now you've learned that. What are you thinking now in terms of your differential diagnosis based on this new information?
The patient presented with photophobia, phonophobia, and unilateral temporal headache with pulsatile character of pain. So these are the typical signs of migraine headache, but the duration is of 1.5 hours. And I have read that migraine headaches usually last for up to 4 to 8 hours. So this might put me off from a diagnosis of migraine. And the patient had a similar history of pain for 1 year. So I also might think about the primary headache syndromes, and looking at the duration of 1.5 hours, I may think of hemicrania continua, which also occurs unilaterally. And I also like to keep the medication overuse headache in differential diagnosis, as a patient is chronically taking the painkillers. Those are my thoughts. And
yeah, fantastic thoughts. Some of the things you said may be new concepts to some people joining us today. Can you teach folks a little bit about what you know about hemicrania continua?
Yes. So hemicrania continua is one of the primary headache syndromes, and it usually presents with unilateral headache, and it usually its duration is about 1 to 2 hours, and the indomethacin like NSAIDs are drug of choice to treat these kinds of headaches.
Yeah, excellent. So not many people know about this diagnosis, but when we think about primary headache disorders, migraine is extremely common, tension is extremely common, and cluster is not very common, but it's common on the board, so everyone has heard of it, right? But cluster actually falls, as Darmeen said, under a broader umbrella of primary headache disorders called the trigeminal autonomic cephalgias, which include cluster, include paroxysmal hemicrania, hemicrania continua, and then SUNCT and SUNA, which stand for sudden onset unilateral headache with nasal congestion and tearing. And I always have to look these up because they're super rare. They're defined by the trigeminal autonomic part is that there is tearing and nasal congestion, and there can be even edema around the eye and ptosis and other things that you hear about in cluster. And then they're really defined by the length of the episode. So SUNCT and SUNA, I forget, there may be minutes, and they happen countless, hundreds of times a day. Paroxysmal hemicrania, they're a little longer and happen fewer times a day, maybe in the 10s to 20s. I'm making this up, I would have to look it up. And then hemicrania continua is longer or more continuous, and cluster is the longest. And also the cluster comes from the fact that it tends to cluster at a particular time of year. The patient will get a cluster headache every day for a couple of weeks or something like that. So fantastic. So just so people enrich the number of things that go under that sort of cluster diagnosis. And there are many primary headache disorders, right? And often if it's a confusing headache disorder, concerning headache disorder, we will image the patient to make sure we're not missing anything. But sometimes the best we can do is a description, and there is a very helpful guide online called the ICHD, or the International something of headache disorders. What's the C stand for? I forget. Anyway, H and D are headache disorders. And you can look this up. And I call it the taxonomy of flowering plants of headache. It's like one of those books where there's just a million pictures of plants in it, and each one has its own Latin name. There's primary stabbing headache. There's primary exertional headache. There's nummular headache, the shape of a coin. There's thousands of headaches in here that sometimes it's helpful to international classification. That's the C, of course. It's like the DSM for headache, right? You can describe a clear syndrome that occurs, but we don't have a biomarker for it. So these can be read about there to get a sense of how long they last and what features you'd be looking for, and see if the patient kind of fits. Great. You also mentioned a medication overuse headache, Darmeen, something that is extremely common and often underdiagnosed. Can you teach us a little bit about that?
Medication overuse headache is associated with chronic use of painkiller drugs. So the chronic use of painkiller drugs makes the patient habituated to its effect, and when patient stop taking it, the headache rebounds. So patient has to again take the painkiller medication to get relief from the headache. This is my limited understanding of this disorder.
I agree with everything you said except the word limited, because that was not a limited understanding at all. That was excellent. So again, you can look at the ICHD and see what the criteria are, but this is a very common situation. Patient has an episodic headache disorder, migraine, or often tension. They take a Tylenol so they can get through the day, and they find it helps them. And the next day they say, I have a little headache. I better just take the Tylenol so I get through the day today. And before they know it, I've seen patients taking Q4 Tylenol, for months and months and months. It's bad for your liver, right? For NSAIDs, it's bad for your kidneys. But it also causes these, we don't really understand the physiology, but presumably some type of rebound headache where the body gets used to the analgesia. It's not addiction withdrawal, but it's some type of rebound effect. And the criteria, if I'm not mistaken, are if you're taking just one non-opioid analgesic, so an NSAID or Tylenol, you only have to take it 15 days a month for 3 months or more to get this. So it doesn't have to be every day. And so if you ask the patient, how often do you take Tylenol? And they say, maybe once a week. And you say, how are you sure? Well, maybe twice a week. Once you're every other day with one medication overuse headache. Very, very common. I see Maria's making a face. She's in a primary care clinic. I'm sure you see this all the time, and we see it all the time. And if you're taking more than one, so if you take mixing aspirin and Tylenol, or NSAIDs and Tylenol, or a triptan and Tylenol, or you're taking an opiate, then it only needs 10 days a month. So that's just twice a week, right, to do this. I had one colleague who said he didn't believe in this, and so he just took NSAIDs for 3 months to see what would happen, and he felt that he had a headache after that. Probably had a GI bleed also. Okay, so no, didn't have a GI bleed, fortunately, but this is the old school of figure it out within yourself. But this is there's a recent paper actually a few years ago, people refuting this and saying it was really not a real condition. It was a way of physicians blaming patients for their own pain, which is an interesting way of framing it. But in my clinical experience, this is very common. And when you tell patients, this is what's happening, you have migraine, but you also have medication overuse headache. We're going to start you on a migraine prophylactic and pull you off these medicines for 2 weeks. You're going to curse me and have rebound headaches that are going to really trouble you. And after that, you'll feel much better. It works. So something about this it seems to me to be to work, and it is in this criteria, but just so you know, people have challenged it. Okay, so you're thinking this could be a primary headache disorder in the TAC, in the TAC, trigeminal autonomic cephalgia family. What do you think, Vijay?
It was like amazing discussion. One thing that just puts me off is first I would like to question even the diagnosis of migraine. Especially migraine in a male, this like always have been taught to take it with a pinch of salt. It's always, and the patient is too young, is only 35. So I would think it's more prudent to rule out secondary causes before I would label it as a primary headache. First thing. Second thing is the temporal headache with photophobia and phonophobia. And this been there for on and off with no response to medication. So is there something else inside the cranial cavity that is causing this? Is there stretch, vessel, or dura, meninges. So especially the pain sensitive structures that we discussed. I'm not thinking of a head and neck cause here. And also because there is also significant history for smoking and vaccination that is there. So that also triggers many things. So one is smokers. Is there any vasospasm that is going on? Smoking is known to cause vasospasms. And the other thing is, like you had mentioned, vaccination for COVID. So what is the relation between the duration of the vaccine and the onset of these migraines? Because COVID per se or the vaccine itself is known to worsen all of the underlying disorders. And the other thing is, I would like to think, is there, this is sort of like what I've seen that many times, many of the cortical venous thrombosis, vascular causes, they present many of times, they come to the OPD exactly like this. So that also is high in the differential, because if it is, let's say, only one-sided, so it can mimic like a one-sided unilateral headache, a lateral sinus thrombosis or something. And again, one more thing that is glaring here is there is no response to NSAID. So that means it is not usually like primary headaches usually respond well to NSAIDs. So other possibility is like we discussed, the NSAID or overuse headache. But since it is all new onset and worsening since 15 days, I would think more in terms of something else happening in the brain or within the cranial cavity rather than calling it a primary headache per se.
Fantastic. Yeah, I agree with you. There are some features on the surface of this, as Darmin said, that could fit with a primary headache syndrome, but there are some other concerning features as well that might make it give us pause before saying so. That this is a new headache that is very persistent, right? That it's not responding to any medications. There are some hints Gabby gave us, right? That it's not worse with exertion, it's not worse when lying down, it's not worse with coughing. Doesn't give us a feel for intracranial pressure being elevated, but that's not the only red flag to look for. So headache is really difficult. We see lots of patients with headache in neurology, and I do a lot of precepting of residents, and the resident will come and say, this person of this age has a new headache, but their exam is normal and they look fine, and I don't really want to image them because I think it's just migraine. But there might be something there. Well, the patient's 50 and they're having their first migraine. They say the patient just looks anxious and stressed, and it seems like a tension headache. And it's one of those things in medicine where I feel like there's some places where everything is ambiguous, and it's, you just have to do your best. But some places where it's important to have some strong principles. And sometimes I'll say to the resident, but this is a new headache, right? This is a new headache in someone without a prior history of headache, or this is a change. We should image this patient, right? In a place where imaging is widely available. And they'll say, but we don't need to, right? Because they look fine, and I think they just have a tension headache. And then when I go in to see the patient after giving them this whole speech that I'm giving now, I say, you're right, the patient looks totally fine. And I think you're probably right that the MRI is going to be normal. And yet, if you have a rule, why are you breaking it, right? Hobby horse sometime I'm sure will come up in this is TIAs. People say it didn't really sound like a TIA, so we just did the echo, but we didn't do a halter. I said, well, was it a TIA or not? Well, we're not sure. Well, there's no harm in doing an echo and a halter. So if you thought it could be, let's go ahead and do the full thing. You can't kind of have it both ways. And I think headache is one of those where many patients, even with red flags, who told me their headache is waking them up at night and they look fine, and I'm pretty sure they just have a migraine. I image them, I don't find anything. But if the red flag is there, I think you kind of have to look for it. And the main red flag here for me is that this is a new and continuous headache, right? And I think we have to work it up, as Vijay said. Maybe we won't find anything, right? And we'll come back to what Darmin said is good. This patient doesn't have a secondary process causing their headache. Let's see which of these primary syndromes it lines up with. And you made the important point that I forgot to emphasize, which is, why does it matter to decide if it's cluster or SUNCT or SUNA or paroxysmal? Because paroxysmal hemicrania and hemicrania continua are uniquely responsive to indomethacin. You can get amazing relief with this drug. It's almost magical, but it doesn't respond to others. And the others don't respond to that. So there is some value in saying what primary headache disorder this is. But there's some literature to suggest that even if you say this patient has cluster, it's 100% perfect, it meets all the criteria, that you should still image these patients, because even migraine can be secondary. Patients can have the semiology of migraine, a visual scintillating cytoma aura, a pulsating unilateral headache, and they have an occipital lobe lesion. I saw a patient who presented with what sounded like migraine. They had had a small occipital stroke, and that stroke was disrupting the visual cortex, and as a result, causing visual aura that looked like migraine and pain. Ischemic stroke doesn't usually cause pain, but can. So I agree, even if we thought this was a primary headache disorder, it's new and it's not clearly falling into a clear category. We'd have to make sure it's not a secondary primary headache disorder, which is a confusing way of saying the syndrome, but being triggered by a lesion. And the other thing I was going to say was, you mentioned, so if this is a secondary headache disorder, Vijay, what could it be? And you make the interesting point, right, that these are very brief episodes that are pulsatile and intense and then kind of remit. Could this be some type of vasospasm? Interesting hypothesis. There's a condition called reversible cerebral vasoconstriction syndrome, RCVS. You mentioned smoking. Maybe you can tell me, I'm not sure it's related to cigarette smoking, but can be triggered by marijuana smoking, can be triggered by SSRIs, has a long list of triggers. I saw a case once where a woman was having this from drinking licorice tea. Licorice has all this interesting medicine that it can do stuff to the kidneys. We didn't have a better source, and these cause these very severe pulsatile headaches, and on imaging you can see vasospasm. You can see this with eclampsia as well as sort of peripartum angiopathy. And another thing you mentioned, depending on which COVID vaccine this was, right? We know with some of the non-mRNA vaccines that they can cause venous sinus thrombosis as part of this VITT syndrome. Usually the headache with those is a little more continuous, progressive, because it's intracranial pressure headache, right? The venous outflow is blocked, and not the sort of intermittent pulsatile with complete remission of pain, but not everything fits into unique categories. So I guess I would pose this question to both of you. No matter what we see on the exam, is there anything on the exam that would, framing the question, maybe not the right way, reassure you enough to not get a scan on this patient? In other words, if you saw a completely normal exam, you do fundoscopy, fundus looks fine, patient looks normal, they look fine. If imaging is available, would you say, I think we can watch and wait on this one and try some other medicines, or would you feel obliged to image this patient? What do you think? Quick votes on this one.
I would like
for
to.
imaging.
Yeah, both for images. Yeah, I would agree with you. Now, if you're in a setting where it's very hard to get imaging, or the patient would have to pay for it, it's very expensive, and the patient really looks fine, you could try to treat the symptom and tell them to come back in a week and hope that you luck out. But ideally, if you can, you probably want to image this patient. So if this is neurology, I would never say, well, the exam's not really going to change what I would do. But in this case, obviously, if we saw papilledema, we feel proud of ourselves that even on the history, we already knew we wanted to go look for something serious. If we see a little focal deficit, a little drift on one side, we see a little change in the reflexes on one side. But this is a case where I would do the full exam, of course, to see if it gives me any more information. But the history is enough to say, we got to work this up. So what did you find on the exam, Gabby?
Yeah, awesome. So in the exam, he was well appearing, vitals were normal. Neuro exam, everything was normal, including fundoscopy. And the head exam, he had a moderate pain to palpation of the great occipital nerve in the left side. He was not sure, but the pain was very intense, and he said it would, when I touched the great occipital nerve in the left side, he thought the headache was similar to the one that he was having. Then I ordered him imaging because of the presence of the red flags. Oh,
1 second, Gabby. Perfect. Yeah,
okay.
Let's talk a little bit about the exam, if that's okay.
Mm-hmm.
So normal exam, as we anticipated, as people who come to this Tuesday session regularly know, I always like to think before the exam, what am I looking for? Just like before I see imaging, what do I think I'm going to see? So that either I can have the emotional balance of being surprised and learning from that, or being satisfied and learning from that, that my history and my exam were consistent and okay, or my history and exam were inconsistent, let's go back to the drawing board. So we were kind of expecting a normal exam, and Gabby, being a detailed examiner, did something clever here that I'm not sure I would have initially thought to do based on the way we've understood the history, but good for you for doing it. And does anyone get a sense of what Gabby was looking for there and what she may have found? And does it change now whether we need the imaging or not? Going back on what I said before, what about this pain and triggering of the headache back here over the occipital condyle? Does that
I
ring
think
any
this would indicate cervical spondylotic nerve compression that can cause pain.
Okay, one possibility could be so-called cervicogenic headache, that this patient has some musculoskeletal issue there that Gabby has found at the muscle insertion over the spine that is causing so-called cervicogenic headache, that the neck muscles are tense and who knows why, but the experience is headache. Other thoughts on what this could represent? Gabby and I are speaking to each other, and it's like neurology code language. I know exactly what she's thinking when she's doing this test, but we'll all get to learn something if people aren't sure what she's getting at here.
I'm not really sure. Is it that there can be a compression here for some cause? Excuse me.
Yeah.
I'm thinking of that. Other thing, I don't know if this could be possible. I'm thinking of, could the styloid process do something like this? I'm not really sure. The Eagle syndrome, I'm not sure if it can cause something like this.
Good for you. Yeah.
And those are my thoughts.
Yeah, good for you for knowing Eagle syndrome. I don't think that's what's going on here, but just for fun, do you want to tell people what Eagle syndrome is?
There's an elongated styloid process compared to the normal. There, it can compress over the carotid sheath, so the structures around the carotid sheath, so it can present with syncope and persistent headaches because of the compression.
Yeah, good for you. I haven't seen a case, but if someone wants to put in the chat, one of my co-residents saw a case where the patient had the CT 3D reconstruction that they published looks like tusks on a walrus. It's unbelievable. The author is Vodopivec, Vodopivec. It's probably from around 2012, 2013 when we were residents. I think the patient had a carotid dissection from it. Anyway, that's Eagle syndrome. I've never seen it, but it's fun to talk about. So Gabby, do you want to tell us what you were looking for tapping over the occipital condyle and what you may have found there, what diagnosis you were thinking about so people can learn from it?
Yeah, of course. So when I tried to palpate those parts of the skull, I was looking for one of the signs of occipital neuralgia, which is like an inflammation in one of the occipital nerves that innervate half of our heads, and sometimes it can inflame and trigger a very unusual and intense headache. I don't remember all the topics to diagnose it, but one of the topics that is necessary is that the headache must be triggered by the palpation of the nerve. So you have 4 places to palpate the nerves. You have the great occipital nerve, where you palpate 1.5 centimeter down and to the right or left, here in the occipital position, and then you also have the small occipital nerve. I don't know how to say in English, but it's close to the ear. Lesser, yeah, thanks. So you have to palpate those 4 places, and this kind of headache is responsible to lidocaine injection in the place of the nerve. So that's what I was looking for.
Yeah. Good for you. So yeah, usually the patients will describe, so trigeminal neuralgia, which most people know, right, is very severe electrical shooting pain in the V2 and V3 distribution. The trigeminal nerve does the face, but there are root branches of C1 and C2 that give the sensory innervation of the scalp, the greater and lesser occipital nerves amongst those. And just like you can have trigeminal neuralgia, you can have any nerve neuralgia, you can have this occipital neuralgia. And usually the patient will do this symbol, like people say, you know, heart attack, universal symbol, people make a tight fist in front of their chest. They say it sort of zips around here or zaps, not quite the history we got here, but worth looking for. And just like in carpal tunnel syndrome, you can look for the Tinel sign, which is neither sensitive nor specific, but we do it anyway. Here, if you tap back there, sometimes the patient will say, that's it. It's like a shot of electricity across my head. And I think the diagnostic criteria even say that treatment is diagnosis here. You do a lidocaine injection and it goes away. But if patients don't want that, just like with trigeminal neuralgia, you can use a little gabapentin. Would I image for this? In principle, I would. You never know if there's a mass there at the C1 level pushing on this thing. I've seen a handful of cases of this and I've imaged them to be diligent and never found anything. There's no, you don't get disc protrusions up at that level. That part of the spine is very fixed, right? So you're not getting disc protrusions into your into your brainstem, right? That would be bad news. So I'm not sure what else could be there, but presumably a soft tissue mass or something like that. But usually the characteristics, and Gabby, maybe you can correct me if we misunderstood the history, a little more, they are unilateral, which you gave us, but a little more electrical. And I wouldn't expect the photophobia, phonophobia. So there are some aspects here where you might say, well, you found this on exam, but it wouldn't really explain everything. Oh, Gabby is now writing to us. Yeah. So you found this, but the patient may have it and it might not explain the whole thing. And gee, for it to come on and be this frequent and sudden, probably less likely. Okay, so we all agreed, even no matter what we found, we would get a scan. And even here we said, oh, well, it's just occipital neuralgia. Well, I would still scan in those cases. Okay, so you got your scan and let's do a prediction here. Darmeen, Vijay, are we gonna see anything on this scan? What do people think? You can just tell me you think it'll be normal or abnormal.
I really don't know, as I don't have any clues to suggest.
Yeah, okay, so you
Whether
think
I
it'll be
should-
normal? Yeah.
I still think there could be something abnormal. Because there are some many points in the history that are not typically featuring suboccipital neuralgia. This episodic, pulsatile, worsening symptoms. I'm not sure that it fits the entire picture for suboccipital neuralgia. And given the distribution of C1, C2 dermatome being there, so is there something in the high cervical cord compressing over the nerve roots? That is still a possibility. So what would that be? So it could be anything that could impinge over the nerve. So I still think it still will have some signature on the imaging.
Yeah. I'm always torn. I always ask this question to residents and students that I think about. I think, what am I gonna say on this one? This patient has a lot of red flags from the history and yet looks really good on the exam. So I guess the question is, what could they still have that's not giving us any focality, that's not giving us any fever, that's not giving us any ICP clues? Your hypothesis of vasospasm remains an interesting one for this sort of brief episodes, though usually these are really severe, almost thunderclap in nature, and that the patient would spend 15 days with this and not go to the hospital. I guess went to the hospital once, but it's usually very severe. Patients go to the emergency room. But are we going to see anything in the brain parenchyma? Doesn't seem like it, but I'm not sure. But I always think it's still worthwhile doing this exercise to get a sense of what you think you might or might not see, and see how well your clinical intuition lines up with the scan. Okay, the suspense has us waiting. Gabby, what did you see on this exam, in this MRI? We're not sure what we're going to think. I think we have Darmeen a vote for normal, Vijay a vote for abnormal, and I think I'm going to come down on abnormal, but not in the parenchyma. So I guess that means the vessels are meninges, and I guess I'm in the vessels. But I won't be shocked if it's normal. That's how I'll put it, I guess.
Yeah, awesome thoughts. It's interesting because I was also thinking about should I order image or not, because he had some red flags, but at the same time he had he had many episodes like this since his 20s. So it was a new headache, but this one was a little bit more progressive than what he had before. So I was curious, and then I found out the greater occipital nerve triggering the headache, but I was not totally convinced. Even though I discussed everything with the patient and we decided to order the image because we were not sure, and it was normal. And I have one last aliquot before the diagnosis. When I saw him, I decided to do the infiltration, the lidocaine infiltration, and order the image in the same appointment. After the infiltration, he got 4 days without any pain, but then the pain returned as they were before. When he returned, I think 1 week later, and in this appointment, I asked him to look for any autonomic symptoms during the episodes and to time the duration of the episodes. At the same time, I told him that he should go to the ER and maybe be put on oxygen if he had any other episodes like that, because if he was responsible to oxygen, it could be cluster headache. Because this case, he wasn't sure about the duration of the headache, because they were so intense and he couldn't know. That's what I asked him to do. And then he returned one week later. And then he told me that during the episodes, he actually had eyelid edema, ptosis and lacrimation on the left side. And he thinks he also had meiosis. He was able to time the episodes, and the average was 20 minutes. And he had 5 to 10 episodes per day. I asked him to do a headache diary, and he came with this diagram where he painted green, no headache, and red headache, and which drugs he used. And it was very visual and easy to see how things happened. And then when he told me this, I thought about the diagnosis and started treatment.
All right, good. I was hoping you would pause before you finally called this. So good, excellent. So a lot of our intuitions here are interesting, right? Because we kind of had the sense, Darmeen, early on that this fit into some type of primary headache disorder in the cluster family, trigeminal autonomic cephalgia family, but it didn't have the autonomic stuff that we would need to meet criteria, unless you have a brilliant clinician like Gabby, who doesn't just say, here's some medicines and call me if you get worse. Says, no, you need to look for these things when you come back and see if this falls into more of a category. And yet this is new, it's different, it's intense, we had to image. But as we said, it might come back normal, and we would have to then see what bucket this fits into. So if these are 5 to 10, 20-minute episodes a day of unilateral trigeminal autonomic cephalgia symptoms, does anyone know which one that would be? I think I know which one it is, but I'm actually not sure. I'd have to look at the table I made for myself to remember these. Anyone know which one that would be? So our choices are, is it a cluster headache? Is it SUNCT? Is it SUNA? Is it paroxysmal hemicrania, or is it hemicrania continua? Does it fit into one of those? Yeah, Maria, chapter 26, table 2.
I think it fits into a cluster headache.
So you're thinking cluster headache, and what are you thinking, Darmeen?
I don't exactly know the duration. So I am also thinking about cluster headache.
Yeah, so I think cluster headache is usually 15 minutes to 3 hours. Maria, you can check me here. Maria's going to be our fact checker here. 15 minutes to 3 hours. And usually a very severe. Now this patient is having severe pain, but seems to be going about their life. This is usually, it's described in literature as boring pain, which I always thought meant, like a boring lecture, but boring like a drill boring into the head, boring meaning of that, boring pain. SUNCT and SUNA are super brief. It's like hundreds of couple-minute episodes a day. Maria's our streaming fact checker. Okay. And then, so what that leaves us is either paroxysmal hemicrania or hemicrania continua, And this seems to me more paroxysmal than continua. And I think this fits of about 10 minutes and about less than a dozen episodes a day. But Maria can tell us what the exact, or Gabby can tell us the exact thing. So I would say this is probably, you were very close to, calling this paroxysmal hemicrania, or hemicrania continua. I think this is paroxysmal hemicrania, and the answer would come from an indomethacin trial. Tell us what you thought, Gabby.
Yeah, so I thought he had paroxysmal hemicrania, and I started him on indomethacin, 25 milligrams 3 times a day. And he said that after the second day of the medication, the pain completely resolved. So this was the final diagnosis. I think for continuous hemicrania, you have to have pain every day for at least 1 year. So he didn't have that. And I think, at least for me, this case was important to show, first, because if you don't ask, you never know. Like I didn't ask for the first time if he had any autonomic symptoms. The second is that the duration of the pain is really useful. So if you are worried, just ask the patient to time and tell the person why this is important. And third, never believe in a previous diagnosis. Like he believed he had migraines, but it never worked. He used medications for migraine and it didn't work. So this case was very, I learned a lot with him, and I'm glad he's feeling good now.
Yeah,
Thank
amazing.
you. It was an amazing discussion.
Amazingly diagnosed and treated here. And this case has another interesting thread, which is sometimes treatment is diagnosis, right? So there was a component of occipital neuralgia there, though Gabby very astutely saw it didn't all fit, but maybe there was some occipital neuralgia triggering some other thing, and so she treated that, but it didn't work. And similarly with paroxysmal hemicrania continua, why they respond to indomethacin and not other things is unclear, but it's been described in the 1 or 2 cases I've seen, just as Gabby said, it's night and day. It's like starting a patient with advanced Parkinson's on carbidopa, levodopa. If you're not sure if they have Parkinson's, within 2 days, if they have it, they're much better, right? If you've seen that phenomenon. And similarly with this, less dramatic because the patient is not going from statue to walking, but it's within a couple of days. If this is the right diagnosis, if you titrate up the medicine, either responds or it doesn't. So good for you for being persistent. Another good important lesson for outpatient medicine, those of you who are residents know that feels like we're always trying to get the answer while the patient's in the hospital, and we spend most of residency doing that. When I started my real life not real life, but I started my professional career outside of residency. I hope my life was real before that, and was doing a lot more outpatient. I often felt like, oh, I didn't figure it out. The patient came here, they sometimes came from far away. I asked them a lot of stuff, I examined them, I ordered some tests, and then they went away. And I remember one of my mentors saying, cool off, many of these you're not going to figure out in the first visit. If it was an emergency, you'd send them to the hospital to figure it out. Now, if it's not an emergency, let it play out over time and you'll get your answer, or you'll get a flavor for whether this is serious, evolving, and you're not being aggressive enough in pursuing a diagnosis, or it's actually getting better on its own and you might not get the answer, or there's less urgency and less cost associated with just doing a million tests. Fantastic. Well, thank you for bringing us this case, Gabby. Brilliantly diagnosed, treated, and presented. Brilliant discussion, Darmeen and Vijay, as we oscillated between primary and secondary headache disorders, and both were on the table, I think, till the end here. And a good real life example of, we do these things in aliquots, but in real life, the aliquots keep coming and they don't always come in the right order. And had Gabby given us the history she got later at the beginning, were it available, we might have seen this differently. So great way to present it so we could learn a lot. Great discussion, Darmeen and Vijay. And I think Gabrielle has some teaching points for us.
Thank you everyone for the opportunity of doing the teaching points. Such a great case. I also remember presenting a similar case of hemicrania continua in an adult woman, but also it was secondary to an hemangioma. Thank you so much. I learned a lot. So for starting the teaching points, at first we were approaching the chief concern that was a worsening of headaches. So we have to keep in mind that a pattern change of the headache is a red flag. So we were working in the localization, and we can divide it in terms of headache, we can divide it into two big categories that are the primary headaches and the secondary headaches. So our first problem representation was a unilateral recurrent headache episodes of 1.5 hours in an adult man. So in terms of primary headaches, we were thinking about trigeminal autonomic cephalgias. And there are different types of this category. Some clues that can help us to differentiate the types of these cephalgias are the attack duration and the frequency attacks. So in terms of the attack duration in crescendo order, we have the SUN, the SUNA, paroxysmal hemicrania, the cluster, and hemicrania continua. So for the paroxysmal hemicrania typically last less than 30 minutes, and the cluster typically lasts less than 180 minutes. So we were thinking if this could be a paroxysmal hemicrania, cluster, or hemicrania continua. And in terms of the, also we were thinking we have to inquire about the medication compliance, because headaches, the episodes of headaches can worsen due to a medication overuse or medication non-compliance. In terms of the secondary headaches, we have red flags that was the worsening of headaches as itself. So the presence of a red flags requires workup. So imaging could be needed, but this is not as black and white, and we can communicate with the patient our worries and decide together if an image, if pursue an image. We in this category we were thinking about vascular infectious events. So moving on the localization, in the physical exam, we have a localized pain in the occipital nerve region. So we were thinking about occipital neuralgia and the Eagle syndrome. And there's a type of Eagle syndrome that is unrelated to the tonsillectomy or throat traumas that is due to a compression of the carotid artery branches. So later on, sharpening our problem representation, we have a unilateral 20 minutes headache with autonomic symptoms and plus a normal imaging. So this problem representation points toward cluster headache or paroxysmal hemicrania. And then finishing the puzzle, the patient responds to indomethacin. So this points toward a hypothesis of paroxysmal hemicrania. Thank you so much for connecting, and see you tomorrow.
Great, fantastic teaching points, Gabrielle. Thanks again, Gabriella, for bringing us this case and showing us your phenomenal clinical reasoning to get this patient to the diagnosis and treatment. And Vijay and Darmeen, brilliant discussion of a complicated case, and allowed us to review some core first principles in headache, and also some gourmet trigeminal autonomic cephalgia rare diagnoses in case anyone sees them. Fantastic. Thanks, everyone. See you next week. Have a great week.